Polymyositis and dermatomyositis are autoimmune myopathies that are characterized by proximal muscle weakness due to immune-mediated inflammation of skeletal muscle. Polymyositis involves primarily muscle tissue, while dermatomyositis also affects the skin, hence the name dermato. These disorders are relatively rare, about 5 cases per million per year, with a female predominance. Pediatric variants can occur, and key symptoms include difficulty rising, climbing stairs, or lifting objects due to proximal muscle involvement. Diagnosis is based both on clinical and laboratory data, proximal muscle weakness, elevated serum creatinine kinase, CK, and myopathic changes on electromyography. Muscle biopsy can also be done showing lymphocytic infiltration or inflammation. Dermatomyositis adds a characteristic rash. This can be considered a heliotrope discoloration or Gauthron's papules. Diagnosis is definitive if all 4 criteria are present, and it's probable with 3 criteria and possible with 2. We can do antibody testing to confirm. The cytoplasmic ANA pattern is characteristic of polymyositis and dermatomyositis, and as well as the main antibody being anti-Jo1, which is directed against histidyl tRNA synthetase. Presence of anti-Jo1 is associated with interstitial lung disease, arthritis, and Raynaud's, which together are known as anti-synthetase syndrome. Recognizing this pattern can distinguish inflammatory myopathies from other causes of muscle weakness, drug toxicity, or metabolic disease, for instance. Before ordering these serologic tests, you always want to perform a history and an exam to narrow down the differential diagnosis. Most patients that have joint or muscle pain in primary care do not have autoimmune rheumatologic disease. Because serologies do have false positives, you want to avoid using these as broad screening tools and rather use targeted testing based off the most likely clinical picture to avoid any unnecessary confusion and or cost. Specialized antibody tests like anti-U1RNP, anti-Ro, or anti-LAW should be used as confirmatory tools once autoimmune disease is suspected. And the American College of Rheumatology diagnostic criteria rely primarily on clinical features, not just serology. For instance, rheumatoid arthritis, the anti-CCP antibody is most useful when polyarthritis is already evident. The key principle here will be clinical correlation before serologic confirmation. Now, our next kind of slide transition is going to move us into some immunology tests, the tests for infectious disease. And so we'll come back and look at those in our next video.